Good evening, friends. So, COVID, with whatever else it taught us, also taught us the significance of other investigations, much more than what we have been doing always. We are all used to doing routine investigations, fever profiles, lipid profiles, kidney profile, and all that thing. But now, with advent of more diseases, newer investigations have become important. Some of them we may do in our clinic. Some will be done on our patients when they're admitted. And we have to understand why this test is being done. And if it is being repeated, then why it is being repeated. And when you should talk to the doctor concerned, that is it a treatment failure? So all enlightened family practitioners need to learn these tests little bit more in detail. Hence, this series I have started, miscellaneous lab test, indications, interpretation, and management of abnormal. Because you can't be referring every patient for a very simple management. Today is the first, and I'm sure we will go at least 3 sessions based on the questions that I have received and which are already in my list. Coming to osteoporosis. The diagnostic of osteoporosis is DEXA, used to determine bone density, expressed in gram per centimeter square. There is a T-score which tells you how much the bone density is. And this is the diagrammatic presentation of T-score: green, yellow, and red. Someone with a healthy bone density will have a T-score greater than or equal to -1.0. So -1 to +1 is normal bone density. Osteopenia will have -1 to -2.5. Osteoporosis will have a -2.5 and above. Again, normal or equal to -1.0, normal. Osteopenia -1 to -2.5. Osteoporosis below 2.5. And if the patient suffers a pathological fracture, it should be below 2.5 with fracture is severe osteoporosis. Now, this is very good to diagnose. But when you start biphosphonate treatment, how do you monitor therapy? Repeating DEXA or bone densitometry every 6 months is tedious, expensive, time-consuming, and more importantly, whether that will show, a T-score will show improvement in 6 months is again doubtful. Do we need to treat all osteopenias, or we should wait for some time? For that, this particular test is very important. Serum beta crosslaps or beta CTX, a bone turnover marker. Osteopenia and osteoporosis means the bone resorption is much more than new bone formation. So this is a marker for that. I learned of this test accidentally about 12 years ago. Now I have been using it very frequently. Beta crosslap assay Some labs will understand what you are asking. In other labs, you better write on the prescription pad, advise beta crosslap assay into bracket bone resorption is available as a beta crosslap assay. That's the lab name. Highly specific assay that uses two monoclonal antibodies which recognize the beta form of aspartic acid at the C-terminal end of type 1 collagen. Let's not remember beta form of aspartic acid. Let's just remember collagen. Collagen is important for bone formation. So beta crosslap assay measures that. Monoclonal antibodies measure that. Who to screen? People older than 65, regardless of risk factors. Postmenopausal and have at least one risk factor for osteoporosis, including having fractured a bone without sufficient trigger, having vertebral abnormality, recent onset scoliosis or kyphosis, and you've done a bone densitometry, it shows osteopenia, to treat or not to treat. Osteoporosis, you don't have to ask this question, to treat or not to treat, but osteopenia, you have to ask a question. Never trust a bone densitometry brought by patient, which is done in a cam on the heel. That is not rational and valid. You have to do a proper bone densitometry, wrist, spine, and femur head. Long-term use of medications such as prednisolone that can cause osteoporosis, drugs like azathioprine, methotrexate, which can cause osteoporosis, you must do beta crosslap assay. Type 1 diabetes, chronic liver disease, chronic kidney disease, severe hypothyroidism, hyperthyroidism, or a family history of osteoporosis should be screened. Patient experience early surgical menopause. A patient underwent hysterectomy with bilateral oophorectomy. You should screen early. For the most accurate result, it has to be done on an empty stomach. So even if you collect blood in your clinic, do not collect on a random sample. Tests are normal when it is less than 300 picogram per ml. Above 300 picogram per ml indicates increased bone resorption, which needs to be corrected. In this case, when the beta crosslap is above 300 picogram per ml, they may have osteoporosis or they may have metabolic bone disease, Paget's disease, hyperthyroidism, or hyperparathyroidism. Then, once I have started treatment by phosphonates, osteophos, then I want to check 3 to 6 monthly whether my treatment is working or not. So in assessment of response to therapy with anti-resorption medication, a decrease after 3 to 6 months of more than 25% of pre-treatment value is indicative of an adequate therapeutic response. So suppose you started at 600 and after 6 months, you are getting 410. That is acceptable response that should make you happy. This specificity or this accuracy of results, you will not get by doing T-score alone every 6 months. Anti-resorption medication, alendronate, brand name Osteophos 3570. Risedronate, Risofos 35-150, both of Cipla, Ibandronate, zoledronic acid, that is a injection. It is given for osteoporosis as well as breast metastasis. And lately, denosumab has come, Exgeva, which is a subcutaneous injection costing 20,000 per dose to be given once in 6 months. Many times, your patient's orthopedic surgeon may have advised, patient will come and ask you, doctor, should I take this? I had a patient of osteopenia who was advised denosumab. She had osteopenia and bone densitometry. We did her beta crosslap. She was 250. We did not start. We said we'll wait. Then another test that has become very common now is HSCRP, highly sensitive CRP. CRP, we were aware before only, but COVID made us much more aware of C-reactive protein. And now HSCRP is used commonly in total body health checkups, but then it is not to be done in patients who are not at risk for atherosclerotic or coronary cardiovascular disease, ASCVD. C-reactive protein, everybody knows, but I'm just repeating. It's a protein produced by the liver. It's a non-specific test to check for acute or subacute inflammation in the body. That is all. It will not tell you where the inflammation is. It will not tell you what is the cause of inflammation. You will get CRP high in arthritis. You will get it high in viral disease. You will get it high in bacterial disease. Level rises when there is inflammation throughout the body. It reveals inflammation somewhere in the body, but it cannot pinpoint the exact location or the exact cause of inflammation. HSCRP, can it be predictor of coronary artery disease? Yes, but not alone. It is to be taken with other factors. C-reactive proteins, as we saw during COVID period, the levels rise dramatically during inflammation, and the inflammation also gives rise to interleukin 6. CRP rise is due to a rise of interleukin 6 or IL-6, which is produced predominantly by macrophages. During acute phase response, CRP is indicative of acute inflammation. CRP increases very rapidly within 2 hours of acute insult. It rises above normal limit within 6 hours, and it peaks at 48 hours. That is the way it is. So if you are doing it, maybe in first 48 hours of a patient getting symptomatic, then the first reading you find third reading of CRP still above 100, does not mean it is a very severe inflammation, because acute phase response resolves, the CRP declines with a half hour of 18 hours. So whatever CRP is produced now at 6:30 p.m. on Thursday will decline in 18 hours. A CRP found later in the infection, found higher later in the infection, is the new CRP that is being formed. CRP can rise up to 50,000 fold in acute inflammation, such as during a severe infection. Of course, we have seen highest in COVID. What I have seen is around 400 to 500. But theoretically, it can rise that high. Its level is mainly determined by rate of production because of its constant half-life. So the reading of CRP indicates the newly produced C-reactive protein in response to acute inflammation, because after 18 hours, the previous CRP is going to get eliminated. Above 100 is considered critical. Okay, we may not use the word critical. I will say it is a cause of concern. If you're not identified what the inflammation is, you better hurry up and find. One exception, CRP elevations in the absence of clinically significant inflammation can occur in chronic renal failure. So do not order CRP just for the heck of it. If you suspect there is an inflammation somewhere which you should know the severity, then only you order. Now we come to highly sensitive CRP. A high sensitivity C-reactive protein is more sensitive because, as the name suggests, it is highly sensitive. It can find very small increase in C-reactive protein than a standard CRP can. But you will not do HSCRP for a bacterial or a viral infection. The HSCRP test can also help show the risk of getting coronary artery disease. Now you may wonder, since CRP is inflammation, how come coronary artery disease gives me highly sensitive CRP increase? We'll explain. A high level of HSCRP, why the test got used up commonly is because they saw that people who get heart attacks, especially younger attacks, they have a level of HSCRP which is high. People with past history of acute myocardial infarction are more likely to have another heart attack if they have a high HSCRP level. The risk goes down when their HSCRP level is in the typical range, normal range. So now, when you have a patient of acute infarction in past, or who has known coronary artery disease, when you check lipid profile once in 6 months, you should check HSCRP also, because an elevated HSCRP means higher the risk for a second infarct. HSCRP test is not for everyone, as I said. You can't do it routinely. The test doesn't show the cause of inflammation. This is again non-specific. So you may have a high HSCRP without any involvement of the heart. So in whom it is important? An HSCRP test may be most useful for people whose ASCVD risk is 10 to 20% of chance of heart attack within the next 10 years. As we had discussed 3-4 weeks ago, Framingham score, calculate the ASCVD risk. If this patient has a risk of more than 10 to 20% of a heart attack in next 10 years, then you should do HSCRP. This is known as the intermediate risk. Why now? Why HSCRP more with the risk of coronary artery disease? We'll say that subsequently. The reference range for HSCRP is below 3 milligram per liter. Relative risk of future cardiovascular events based on HSCRP testing estimated as follows. Low risk, below 1, intermediate risk 1 to 3, and high risk above 3. This is in a patient who has a ASCVD risk of 10 to 20% of infarct in next 10 years as per Framingham score. Wait a minute, that one slide. Okay. So that slide somehow got deleted. I'll tell you why CRP goes up. Coronary artery disease means atheromatous plaques inside the coronary arteries. When these atheromatous plaques are formed, that causes inflammation in the arterial walls. That inflammation gives rise to HSCRP. So all chronic ailments, especially atheromatous plaques, have inflammation within, and that is the genesis of HSCRP and the rationale of using HSCRP for predicting coronary artery disease. How do you manage? Sadly, there is no treatment. How do you reduce inflammation? You cannot give Camoral, Fort, or Flogam or similar medicines for this. Increase aerobic exercise like running, brisk walking, swimming, and cycling. Since the patient is already at risk of coronary artery disease, I would say avoid running. Brisk walking, cycling, and swimming is recommended. As per American Society of Sports Medicine, 30 minutes a day, 5 days a week minimum. Quitting smoking is an essential factor. Rather, I would say quitting tobacco. Even tobacco chewing is a risk factor for coronary artery disease. Losing weight also works wonder in this case. So basically, managing HSCRP is lifestyle management, eating heart-healthy diet, things which are good for the heart. Fruits, vegetables, legumes, whole grains, salads are very good. And freshwater fish. Statins also have an anti-inflammatory action as well as have an endothelial stabilization effect. The plaques are formed in the endothelium. So this may help, but caution the patient, this alone will not help. The main crux of management is lifestyle management. Statins may help alongside that. Second one is homocysteine, which is also nowadays done very commonly. So patient, when they come with a full package done on their own, then want you to tell them why the homocysteine is high. It's again another amino acid in the blood. Studies have shown that excess of homocysteine in the blood is related to higher risk of clot formation. Smokers form very good clots. High homocysteine will form good clots and earlier clots. So you have a risk of coronary heart disease, stroke, and peripheral vascular disease. Maybe DVT also. So you have a patient who's got DVT, you should check homocysteine. You have a patient of coronary artery disease, you should check homocysteine. It's also suggested that homocysteine may have an effect on atherosclerosis. It may worsen atherosclerosis. Usually ordered in a patient who has developed a clot either in an artery or a vein, as I said, deep vein thrombosis, or in an artery, or has got symptoms pertaining to symptoms of a vascular block somewhere. Any evidence or any doubt of a clot anywhere in the system, you have to do homocysteine. Pathophysiology, Why does it go up? Most people who have a high homocysteine have folic acid, vitamin B6 or vitamin B12 deficiency. The deficiency of these three vitamins, folic acid is B9, B6 or B12. Replacing these vitamins often helps return the homocysteine level to normal. So if you replace these, homocysteine levels may come to normal. You replace these either by diet or you replace these by supplements. Other possible causes of a high homocysteine level include uncontrolled hypothyroidism, TSH above 50, above 100. Check homocysteine, because TSH above 50, above 100 despite treatment, I would recommend a lipid profile and a ECG immediately. I have now added homocysteine to that package. Normal levels 5 to 15 micromoles per liter, MCMOL per liter. Nearly all that homocysteine converts to other proteins. The patient has more than 50. The excess homocysteine is a risk factor for arterial or venous thrombosis. So again, order very selectively, but think of it as your armamentarium to prevent future clots, because the management is very easy. How do you manage? Folic acid, B9, vitamin B6 and B12 have been shown to have greatest effect at breaking down homocysteine within our body. So you need to increase this by diet. Foods rich in folic acid, vitamin B6 and B12 include green leafy vegetables, spinach, Savoy cabbage. There's a green cabbage. Kale is something like spinach, available very freely nowadays in malls. Brussels sprouts, broccoli and asparagus. In addition, fruits, and people who don't afford expensive salads, even cucumber, tomatoes work wonders. Tab Homocheck, which we commonly use, no sponsorship of the brand, contains folic acid, pyridoxine hydrochloride and cyanocobalamin, is used in addition. Always supplements in addition to the natural diet. Beta B-type natriuretic peptide, BNP, a very commonly done test nowadays, even before deciding to admit a patient to a hospital. Brain natriuretic peptide, B is for brain, is a substance that our body makes and indicates how our heart is working. The pumping action of the heart produces BNP. And rather than doing a 2D echo every time, this will tell us whether the heart is pumping well or not. Whenever heart has to pump harder, when does the heart have to pump harder? When the heart is failing. When the heart is going into failure, it produces more BNP than required. So a high level of BNP is almost diagnostic of heart failure. Our heart releases more BNP when heart failure develops. So it's a very important test. If you have a patient of COPD, a chronic smoker, COPD, diabetes, hypertension. So when he comes with an acute attack of shortness of breath or dyspnea on exertion, a BNP or pro-BNP will tell you whether it is heart failure or is it COPD worsening. is turned into a N-terminal pro-natriuretic peptide. We call it NT-pro-BNP. So the test we do in our labs is called NT-pro-BNP. Levels of both can be higher in people with heart failure. These tests can be used to help figure out if a patient's shortness of breath, as I told you, is caused by heart failure or not. Normal levels are below 100 picogram per ml. Levels above 100 may be a sign of heart failure. But again, 102, 103 you will not take as heart failure. NT-pro-BNP, this is BNP. NT-pro-BNP less than 125 picogram per ml for people below 75 years of age is normal. And for people above 75 years of age, up to 450 is considered normal. Why? Because there is some degenerative amount of cardiac dysfunction. People above 75 normally will have a little lower ejection fraction. So that is why we allow that concession. So up to 450 picogram per ml of pro-BNP for above 75 patients. Anti-pro-BNP over 900 is sign of heart failure in everyone. And believe me, 900 is not a high number. We have seen 8,000, 10,000, 12,000 also. How does it come down? Heart failure medications like beta blockers, ACE inhibitors, and diuretics will lower BNP and pro-BNP. So it also has a prognostic value. It has a diagnostic value, it has a prognostic value. Procalcitonin, another very important test. If you've seen, I had taken a talk on sepsis maybe a year ago, because nowadays we get sepsis in the smallest of infection because of the low immunity of the host. COVID showed us that sepsis is very common. Procalcitonin is a test for sepsis. Traditional biomarkers, including C-reactive protein, high WBC count, high ESR, and clinical signs and symptoms, are not sufficiently sensitive or specific to guide treatment decision in infectious febrile illness. Fever due to infections. Now, even if patient has fever of 104, even if patient has WBC of 28,000, 90% neutrophil, that will only be called a severe infection. That is not enough to label it as a sepsis. Procalcitonin is a peptide precursor of the hormone called calcitonin. The level of procalcitonin rises in response to a pro-inflammatory stimulus, especially of bacterial origin. You will not get procalcitonin high in a viral infection. The high PCT level, high procalcitonin level produced during infection are not followed by a parallel increase in calcitonin or serum calcium level. So you may say that since it is a precursor of calcitonin, why not measure calcitonin? No. In infections, calcitonin does not rise as much as procalcitonin rises sensitively. In 1993, it's not a very old investigation, just 30 years, a positive correlation was demonstrated between high procalcitonin and patients with positive findings for bacterial infection and sepsis. How do you confirm? positive blood cultures, not positive urine culture. Sepsis is infection, bacterial infection of the blood. In lay language, sepsis is blood poisoning of the entire bloodstream. Further, it was demonstrated that procalcitonin did not elevate in viral infections, and serum levels would decrease following administration of appropriate antibiotic therapy. So once again, it helps me in diagnosis, it helps me in monitoring therapy, it helps me in prognosis. Since it's a biomarker that is released in bacterial infections, it is used to differentiate etiology. Patient is extremely sick. Procalcitonin is normal. So I will say, okay, viral, fungal, or some other cause, but not bacterial. It's correlated with extent and severity of infection. So it's not that positive, negative. The quantified value is important to tell you if it is very high, patient is in severe sepsis. I must give a word of caution here. Please do not order procalcitonin in the clinic to decide on patient treatment, because every patient of sepsis is at a risk of one organ compromise at least, either brain in the form of encephalopathy, altered sensorium, or heart in the form of cardiovascular shock requiring inotropes, or kidney, acute renal failure, or lungs, acute respiratory distress syndrome. So please keep in mind, this is for your knowledge. When your patient is being asked to do this repeatedly in the hospital, it is not for our OPD test. Yes, if the patient is discharged, later on you may do to ensure that it reaches normal. But otherwise, none of us would want a sepsis patient in our clinic. Can be employed as a tool to guide appropriate antibiotic therapy, and thus has a role in antibiotic stewardship. What is antibiotic stewardship? We all have to pledge that we do not use unnecessary antibiotics. Other inflammatory markers like C-reactive proteins lack the specificity required to diagnose bacterial versus non-bacterial infections accurately. As we said initially, CRP cannot tell you is it bacterial or non-bacterial or viral, or is it just a very acute attack of rheumatoid arthritis. PCT-SS still has a specificity of 79%, but it is a gold test. If there is a sepsis, procalcitonin should be high and there should be one organ showing dysfunction evidence. Of course, if the patient is low immunity, that one organ dysfunction will go into multi-organ dysfunction syndrome and may prove fatal. So they have been developed and utilized in 1993 to accurately tell the treating doctor whether the infection is bacterial or else. The reference value for procalcitonin in adults is below 0.1 nanogram per ml. Levels higher than 0.25 nanogram will indicate sepsis, and higher than that is severe sepsis. This is a flowchart I am showing. It is not for us. As I said, we don't want to treat sepsis in the clinic. But septic patients on antibiotic therapy, repeat PCD test below 0.25 or reduced by 90% of basal value, stopping antibiotic therapy strongly encouraged if clinical improvement. If PCT 0.25 to 0.5 and PCT levels have dropped by 80% or more, Stopping antibiotic therapy is encouraged if clinical improvement is there. But don't go by PCT alone. Continue antibiotic therapy if patient is clinically unstable. Clinical reevaluation advised. Repeat procalcitonin every 1 to 2 days. On the other hand, procalcitonin above 0.5 and PCT levels have reduced from base by less than 80%. Continuing antibiotic therapy encouraged, and more than one, and PCT levels have increased over the basal. Continuing antibiotic therapy is strongly encouraged. Reevaluation advised. Repeat PCT every 1 to 2 days. If PCT remains high, then consider that as treatment failure. Your antibiotics have not been successful in treating the bacterial source. It's 6:45. I think I'll stop here. Why? Because next time I'm going to talk on the entire cycle of calcium, serum calcium, ionic calcium, parathyroid hormone, phosphate, and their all correlation. So I don't want that to do in a hurry. So we'll stop today at this stage and then we'll do it next time. Slide 8 to 10, okay. Apolipoprotein AB, lipoprotein A, LP. Dr. Kamath will be doing cardiac risk markers subsequently. We're not stopping in one day. Slide 20, slide 30. Lipoprotein again, we'll be doing it. Cost of BNP test, see, I don't know exactly, it is around 800 to 1200. Yes, done in all labs. All NABL accredited labs. CRP, ESR does both increase simultaneously. See, ESR is not indicative of acute inflammation. CRP is. So I would not do ESR. I would do for a chronic inflammation like a tuberculosis or rheumatoid arthritis. How much CRP is dangerous in a normal person? I think above 100, you should start getting worried that I am not reaching anywhere by the treatment if I am not diagnosed. But patients with 400 and all also have survived. Like in COVID, patients, diabetes, blood sugar 500 and cancer survivor have come back after 3 days on ventilator. Eight, 10, 20. Okay. Slides once. Entire slides can't be repeated. You can see the video tomorrow, whole day it will be there. How good is teriparatide for osteoporosis? Yes, it is good. Based on the T-score and the level of beta crosslap. Therocare reports, I don't want to talk. Dr. Ravindra Shezal, you talk to me directly. So slides 8, 10. Slide 20. Slide 10. Slide 8. Recording, okay, we'll make a special provision. Whole of tomorrow and whole of Saturday, the recording will remain. Till midnight on Saturday, the recording will remain. And very soon we are offering you something where you can see any number of videos, any number of times. Thank you. Have a nice evening.